Hello, this is Dr. Scott McLean, and this is a digital case that I recently completed that I want to share with you today. This case goes back about 15 years ago when some implants were placed. So the first implant was placed in 2011. You can see in the molar region, and then in 2014 he was having a problem with his premolar. So in 2014 he had an ASC crown placed over top of an implant. So this meant that he had a cement retained crown in the back and then an angulated screw channel in the front. Then in 2024, he returned again with a problem with his molar with this fracture. So what are your options in a case like this? We'll go through those and just think about different things. So maybe we could do a post-corn crown. I'm not too enthusiastic about that. We also suggested that the patient may do a single molar implant, and he thought about that one. Another option would be to do a 3-unit implant bridge, and then we could also do a partial denture on this type of case, and of course we could always do nothing. So these are some options we gave the patient to think about. The patient decided to make a digital 3-unit multi-unit bridge with angulated screw channels. So this is the new multi-unit bridge, and it shows the zirconia rings in the base of the bridge, which are cement free, and they fit down on top of multi-units. So this is his actual bridge that we fabricated using digital protocols, and has OmniGrip mini screws that are going to be used to go into angulated screw channels to fit on top of the multi-unit. Now we're still using the original design, but there is a new design coming. It's not in Canada. The flexural strength of this is 1230 megapascals. So let's do the digital impression. We'll start with a 3-unit implant bridge, and we can see here that the patient had the tooth extracted and the posterior tooth popped off. It was a cement retained option, but the anterior is an ASC and the back is a gold adapt abutment. So looking at the gold adapt abutment in the posterior, we can see that it was a cemented crown on top of this big gold post. So we used to make them like this, and the abutment was full solid gold. You can imagine the cost of that now at $2,600 US, and we can see that this is just an option that would not be really great. Plus it's a cement retained option, and I'll see when I take this off, we'll look for cement because this has been on 10 years. This is an angulated screw channel and the anterior, so it actually is 2014 vintage. So taking this apart, we're going to unscrew this posterior crown first. So the abutment fit down inside and the crown was cemented on top. We'll use a unigrip driver to remove this, and this allows us to get this off so we can then place a multi-unit abutment on and start to make the new bridge. So it's very easy for the patient, no surgery. We go and we can take this off. We can unscrew it using our unigrip driver and the torque wrench. When we undo the screw, then it's going to pop out and we can then have a look down inside. So I'm backing this off going counterclockwise, and you can see that patient's not having any kind of aggravation or pain or any kind of problem. So as I take this out, you can see the solid piece of gold here. It's a big chunk, and this is the way I used to make these. And if you look down inside, you can see the cement that's been in there for almost more than 10 years. It's been since 2011 that this cement has been locked underneath. And so I'm sorry to say that I was the one who left that in there, but sometimes it happens. So we're going to remove the angulated screw channel crown as well. So the ASC crown is sitting on a NobelActive implant. We look down inside, we'll remove all the debris inside. So there's an actual base on this, a titanium adapter it's called. So this sits on, so I'm going to use my torque control wrench to remove this, and you'll see what happens when I do this. I actually have a little bit of a problem, which is always good to show you how I get through this problem. So taking off the abutment, we're going to use an OmniGrip screwdriver, not the mini, but the OmniGrip itself. And we go in, you can see that when I'm going on this screw, I'm having a hard time engaging it. So, and actually what's happened is that when I was drilling out the resin, I nicked the screw, and so now it won't engage. And so I'm going in trying to get it to engage. So my first thing is to really clean it out well, and then to come in and make sure that I can see if I can get the filler out. And so at this point I think I was using cotton pellets, sterile cotton pellets, but we've gone to Teflon at this point. So when I do this, then I'm not able to engage into that screw. Now as I'm trying to engage the OmniGrip screwdriver, you'll be able to hear it clicking, and clicking means it's not engaging. So hear that sound? Just listen. And that clicking noise means that screw is stripped. So not fun.
It's like it's stripped
In the middle of the day, because let's get this fixed. So I call this a lesson within the lesson. So we're going to remove a strip screw. So the head of the screw, so where the engagement of the OmniGrip into the screw, that is stripped. So we start to take the zirconia crown and cut it in two. You maybe think I'm a crazy man here, but I'm cutting it in two so I can remove that top part of the crown that's sitting on the titanium adapter. The titanium adapter is tightened down right now with the screw. So what I want to do is relieve the pressure off the screw. So the screw is actually stretching at this point. And so if I can cut this zirconia crown in two pieces, then that ring that I showed you, which is also on the ASC, then I'm able to take that off so I can get to the titanium base, and it actually will make the screw become loose. So since it's not holding anything, the zirconia is gone, and the screw is actually going to become wiggly, and it makes it very easy to come out. So it's a easy way to get the angled screw channel. So it's kind of convenient that this showed up today because I can show it to you, but it's not fun when it first happens. But we're talking about this ring of zirconia here. So when the screw head is in the base of that, it actually causes pressure on the screw as you tighten the screw to 35 newtons. So by doing this and getting that zirconia out of there, you can't hit the implant. So we get that out, but here's what's happening. So the implant has the zirconia tie base inside of it, so the titanium adapter. And so when we remove the zirconia, that screw gets loose. There's no pressure on the screw, so we can back it out and get rid of it and get a new screw, or we're going to get a new abutment here. And then we take that titanium adapter out, and then we're able to come back and then put on the multi-unit abutment. So here we go. We're looking down at the screw now. The zirconia has all been removed, and you can see that the screw is loose. You can see it here. You can see it moving when I'm just blowing air on it, and it's now it's going to become an easy project for us. So we can usually take this screw out with just using a screwdriver, reversing it out now because there's no torque on the screw, or we would use a 557 in reverse and pick it, peck at it, and when you peck at it, it's going to pop it out. But here I was just able to do that. Ta-da! We got it out. So this screw, do not use this screw again. This is not something you want to be putting back in the patient's mouth. So our goal now is to remove the titanium adapter. If we can't get this out with just using my screwdriver, then go watch my Zart video, and that'll show you exactly how you take it out if it's stuck down inside. So basically what we've done is we've taken out the screw, and now we've taken out the titanium adapter. Now we can go back in and place the multi-unit abutment, and this is what we want to put the bridge on. So the multi-unit abutment, the new ones look like this. I can't wait to get my hands on these, but we have the original design in this presentation. The new design is available in the States, but I'm going to be using a design that looks like this. So this is the before, when the after is looking like this. So I do think that the vertical tissue is going to be more supported with the new design, but this other design I've been using for a long time in the all-in-4 bridges, and it's worked very well as well. So I like to use a 1.5 millimeter multi-unit abutment on these cases. I don't like to go any further than that. So this is a part number, and we can see that when I put this on, we screw it down, and the tissues actually work quite nicely around this. So this is going to be in the junctional epithelium level, and I'll use a latch driver, tighten it down to at least 15 to 20 newtons. I even go to 25 on these straight abutments because they're one solid piece, and it should be perfectly fine to do that. So here's the two abutments in place, and we're going to connect these with a bridge at this point. So the patient still has not felt one thing. He's just quite amazed by the whole procedure. So we'll go in and we'll get our torque wrench, and we'll turn the arm so that it's going to be able to tighten these abutments down. So we'll touch two parts of the torque wrench, and we'll touch the back of the torque wrench, then also the teardrop, and we'll tighten this down. So there's 15, and you can go a little bit more if you want. So 15 is perfectly fine. So I'm going to about 20 there. So my goal now is that we're going to do a digital multi-unit abutment PoLo scan. So this is the scan body called the multi-unit PoLo scan body. It's a two-piece scan body that you screw together, and you'll pick a size. So I'm going to use an 8mm by 10 in this case, and I'll use two of those, and I'll screw them together and then put it on the multi-units and then do my scan for the bridge. Isn't that exciting? And I can use an intraoral scanner and come over top of it. So these are a little tricky to put on, but what you do is you take the PoLo scan body and you're going to hold it with two fingers and tighten it down. So I do like the torque control for this. So I get it a little bit loose so I can find out where I want to put it, and then I'll tighten it down to about 15 newtons. You can go 10 to 15. And you don't want these to move around during the procedure, so you want these to be tightened down so that they're going to be stable during the intraoral scan. So the intraoral scan, we're going to go over the scans, but basically you're going to do a series of scans. So you do the patient's mouth, and then you come back and you'll do the PoLo scans. But I'll show you how you do this at the very end of the video. So I'll go through the session with that. So looking at this, I'm going to tighten these two down, and I want a little tiny bit of space between the two PoLo scan bodies. And we're going to take a scan of this. So these are really cool. They have all kinds of grooves and markings so that in a 3D format you can pick up where the multi-unit abutments are. So our goal is to know where the PoLo scan body is relative to the multi-unit, but also where the tissue is around the multi-unit. So we have to do two scans because we can't scan the tissue when we have these PoLo scan bodies over top because we can't see the tissue. And you can see that I probably would have taken a little bit more bone off the lingual in this case, but c'est la vie. When I took the tooth out, I didn't notice that, but I think it would have been a bit better if I did that, if I was to, criticize myself. So now I'll remove the PoLos, and then we'll do our final scan. So normally I have it in sequence, and what I would do is do this other scan first, but it just happened to be that this is how it was working. So looking at this, we can see platform shift, a platform shift here with 4 millimeters of tissue above the platform shift. So this is what, and on the posterior, we're not quite as generous here, but we have pretty good platform shifting with soft tissues over top. So this is the goal for this long-term bridge. So this is going to be a really successful bridge, and I think going to be fantastic for the patient. So we're going to do a scan of the white caps as well. These are usually put on as a healing cap on the multi-unit. So when we place these, we screw them down on top of the multi-unit so it holds the tissues out. And this is the way that we can get this to stay healthy when the bridge is being fabricated, and also when the implants are healing. In this case, we didn't have to worry about that. You don't want to over tighten these, because if you over tighten them, they're very difficult to come off because the screw pulls through the plastic. How do I know that? Trust me, we don't want to do that because you have to cut them off then. So I'll tighten these down. They're pretty easy to put on, and they go on the multi-units, and the multi-unit is going to look exactly like this. So it's going below the tissue, and then we want to get a scan of those two objects. So the reason why we want that is so that we can pick up where the multi-unit is relative to the soft tissue. The dental technician will then take all these files from different patient files in your intraoral scan and put them together in either 3Shape, Exocad, or DTX Studio and do the stitching and putting things together so you can make the bridge with high accuracy. So what we can see is as we scan this, we're scanning where the position of these two white caps are relative to each other in the tissue. Then they can stitch this so that they know where the tissue is. But the most important scan is the PoLo scan, because the PoLo scan tells you with accuracy where the bridge is going to be fabricated. So we made this bridge. The dental technician did a beautiful job of making this. You can see the two screws here in the front, which are OmniGrip mini screws. And we can see the zirconia rings that are going to be held by these screws. So you can tip these channels depending on the depth. And now what we'll do is we're going to insert the bridge. So we'll take the bridge to the patient's mouth, and we're going to first take out the white caps, because the patient's going to come back with these in their mouth. And when you take these out, they're usually pretty clean and they look pretty good. And I've been happy with these, except I would probably shape them a little bit different now. I think that as we go forward, we have to have different things. So we're going to take the screwdriver. So the OmniGrip Mini, we're going to take the Unigrip driver out and put the OmniGrip Mini driver in, and it's the gold one with a black line on it as shown here. So this is going to be used to tighten down the screws, and the screws actually then lock on the head of the screwdriver quite nicely. So it's almost like there's an adhesion or a snap, and this is to go through the angled screw channel. You're able to be in any type of position to get the screw to be tightened down up to 25 degrees, depth willing. So if you don't have enough depth, you can't go and angle the screw channel. You have to have some depth. And I think that's what happened here, because in 2011, I wasn't fully guiding everything, and I was also doing cement retained. Those two things are completely reversed in my life now. So every case that I do is guided 100%, and every case I do is non-cemented 100%. So it's very rarely in a 5-year period that I cement anything. Once in a while in the lower anterior, because of the options are limited there sometimes. So as we look at this, we can see that we're going to touch this teardrop and also the back of the screwdriver where your finger goes here, and the driver is going to fit into the screw and tighten down. So you only touch those two spots. So back of the driver on the teardrop. You don't touch the arm when you're tightening this down. And these screws are manufacturer recommended tightened to 20 newtons torque. So 20 is perfectly fine. The screw is going to lengthen a little tiny bit and start to pull the multi-unit abutment and the zirconia underface of the bridge together. And so you can see here that the screw is a little bit on the lingual and the posterior. I think this is because it's not as deep on that aspect. So my goal would be to make sure you're positioning your multi-units to be about 4 millimeter implant platform depth from the tissue, the zenith of the tissue, so you have soft tissue enough to make your multi-unit abutment have a good platform shift in a spot that's going to protect your implant. And so this is where I'm placing these. If I was to place this today, I would do a wax up, digital wax up, and then I would place the implants to be positioned for this bridge. So we'll put the resin in. So I'm using a posterior resin. This one is nice and hard, and so it will last a good long time. We put some Teflon in the channels, so sterile Teflon, and then light cure, and then it's going to be great for the patient. So as we look at this, we can see that this disappears. We can't see where the screw channels are, and it looks beautiful on occlusion. The patient really didn't have to have any adjustments to this bridge. And the x-ray, you can see that the x-ray looks fantastic, how the zirconia bridge fits down on top of the multi-unit abutment. So this was a ton of fun to do. I really enjoyed this case, improving the patient's quality of life. Let's go over the scans. The first scans would be, you take an upper arch, which would be the antagonist here, the lower full arch with the white caps in place, and then you do the left and right bite. This gives you a lot of information in the first scan. Then you'd open up another patient file in the same scan, and you do a scan of the PoLo scan bodies. and this would get you to where you want to go. So this is Dr. Scott McLean, and this has been a presentation about digital multi-unit bridge impressions, getting screws out and doing all kinds of stuff. So hope you enjoyed the video, and please drop me a like and a comment. And I really enjoy making the video for you, and this was actually a real fun one. So take care, and I hope you enjoy the video.